So today's webinar is on primary healthcare organization and models of care. Just a few housekeeping announcements before we start. So you see the Q&A box. All your questions are welcome. So each presentation is followed by a 5-minute Q&A. You can ask your questions then, or you can also send your questions while the speakers are presenting. And in the Q&A box, you can upvote the questions that you like, and we'll make sure that our speakers answer that. I shared the introductory material with you over Google Drive. Now I'd like to invite Dr. Bob Mash, who's the chair of the steering committee of the Primary Healthcare Research Consortium, to introduce the speakers and invite them to speak. Over to you, Bob.
Yes, well, it's good morning, at least where I am. I'm in South Africa, in Cape Town, and welcome to everybody that's joined the webinar. So I'm going to give a very brief introduction to the Primary Healthcare Research Consortium and to our two speakers today, and then we'll get on with things. So a little bit about the consortium. This whole process of setting up this consortium started in about 2016 with a scoping review of the sort of state of primary healthcare in low and middle income countries and what the knowledge gaps are that we need to address. And this was followed by quite an extensive process of meetings and Delphi processes, and eventually led to the setting up of a consortium which consists of these 6 founding members. You can see that it includes the American University of Beirut from Lebanon, the International Center for Diarrheal Disease Research in Bangladesh, Primafamed from Sub-Saharan Africa, which is where I'm sitting, the George Institute for Global Health in India and Australia, and the World Organization of Family Doctors, or WONCA, which is usually based in Bangkok, Thailand. And finally, the George Washington University from the United States. So these 6 founding members continued the work of looking at what are the key sort of evidence gaps around primary healthcare, particularly service delivery, and published their initial work in a supplement to the BMJ Global Health in 2019, where they set out the evidence gaps that they had discovered and the priority research questions that they felt needed to be addressed. The consortium that was established to address these questions had this vision of improving health through strengthening high quality, person-centered primary health care in low and middle income countries. And the activities or mission really of the consortium is to develop, capacitate, conduct, and disseminate LMIC-led, so research that's led by people in low and middle income countries to address these priority questions. And of course, through addressing what we hope are priority questions, to help drive research into action through policymakers and stakeholders, and to catalyze this work through a global network of collaborating partners. So eventually to expand this consortium to include other institutions around the world. So the initial research that's currently underway is happening in, first project actually is in Mexico, Uganda, and India. And in essence, that's looking at the primary healthcare team, the members of that team, how they're integrated and how that relates to the provision of comprehensive primary healthcare. And the second study in El Salvador, Lebanon, and Malawi is looking at how health systems are gathering information on primary healthcare performance and how they're using that information to actually improve primary healthcare. So the consortium, I can't go into all of the ins and outs of the consortium, but if you're interested to know more, there's a very nice website which has got the URL phcrc.world, and you can go there and find out a lot more information. And if you're interested, you can sign up to receive a newsletter and so on from the consortium. We also have quite an extensive advisory committee, which I'm just showing you here. That includes members of civil society, health and development policymakers, the World Health Organization, family medicine, and also the Primary Healthcare Performance Initiative, which is another key partner of the consortium. So one of the ways that we thought of sharing this initial work, much of which was published in the BMJ Global Health, was to have a series of webinars on some of the key themes addressed by that work, so we can showcase the existing evidence, highlight the knowledge gaps, and the priority research questions that need to be addressed. And of course, in these webinars, hopefully to engage with you in a constructive dialogue on primary healthcare. So we did have already, our first webinar was in November last year, and we had two speakers. The one was Fadi El Jadali, who is from Lebanon, and he spoke about the evidence gaps that still exist and need to be addressed through local evidence in the Eastern Mediterranean region. And then we also had a speaker, Beth Twitter, from the Primary Healthcare Performance Initiative, who spoke about the need to carry forward, the momentum from the Astana Declaration and to support cross-country knowledge sharing, measurement and improvement in primary healthcare. You're probably aware that that initiative are trying to establish a set of vital signs for the performance of primary healthcare in countries across the world. The next webinar, which will be in a few weeks' time, is going to focus on primary healthcare policies, governance and financing. And I see we've got our Twitter handle there if you're interested to follow us on Twitter. So today's webinar is on the subject of primary healthcare organization and models of care. So in a way, looking at the models of service delivery for primary healthcare. And we have two excellent speakers. The first one is Felicity Goodyear Smith. So she is coming from WONCA. If you remember, that's the World Organization of Family Doctors, and she heads up their working party on primary care research. And she's also based at the University of Auckland in New Zealand. And she was, up until recently, the head of the department there of general practice. And then Robert Marten is joining us. He's a scientist from the Alliance for Health Policy and Health Systems Research at the World Health Organization. And his interest is in health systems, in non-communicable diseases, and of course in the Sustainable Development Goals, particularly number 3. Looking through his CV, he's worked across the world in India, Japan, Sierra Leone, Zambia, South Africa, Germany, and Vietnam for a variety of organizations, as you can see here. So Felicity is going to focus very much on presenting what the consortium's initial work has told us about models of care and the evidence gap and the priority questions. And Robert Marten is going to focus as one of our key stakeholders and partners on the sort of viewpoint of the Alliance for Health Policy and Health Systems Research on this same topic. And as Manushi has said, please post your questions in the Q&A tab in the webinar as we go along, and then we will have a few minutes after each presentation to look at some of the questions, and then a much longer period at the end. Great. I think that is my introduction to the consortium and to today. So I'm now going to pass over to Felicity for her talk. Thank you, Felicity.
Okay, sorry. Good evening, everyone. I'm in New Zealand, so it's evening here. Good morning and good day to everybody else. So as Bob said, I'm going to talk about primary healthcare organisation and models of care. I think you can hopefully see that. And this is the work that we did prior to the setup of the consortium. So we're looking at trying to identify the research gaps to improve primary healthcare organisation in low and middle income countries. And our WONCA group awarded a contract by Ariadne Labs, who are a recipient of the Bill and Melinda grant. We had a very rough and ready approach because there was a very short time frame of only a few months. And the objectives were to produce 10 to 12 prioritised questions for primary healthcare organisation internationally, with a focus on low and middle income countries. Produce a gap map so we could show where the evidence exists to improve the gap, but where there's major gaps as well. And then we needed to prepare research implementation plans for the top 3 or 4 research questions in specific LMICs. We had a large team. Now, our co-investigators ended up all being from high-income countries, partly because there was no funding to pay investigators, so this was done without funding for the actual investigators, and we weren't able to engage in the short time frame any of our very busy colleagues from low and middle income countries. But we did have advisors from Africa, South Asia and South America. And then when we went to the implementation plans, we had 4 people from LMICs. So this was a survey of countries from, and we recruited 141 participants from 50 LMICs in a week. And we had a diverse range of countries, mostly primary healthcare practitioners, some academics and some policymakers. You can see from the map, the darker the colour, the more participants per country. And to develop the prioritised research questions, we wanted these to come from the people on the ground. We didn't want to come up with them ourselves. And so very much it was a co-design. And we had a 3-round expert panel with our participants. And so in the first round, it was a pre-Delphi round, and we asked them to elicit what are the possible research questions you think are needed to address the knowledge gaps about primary healthcare organisation in your country. And we had 744 responses, and then we put those together, we coded them, collapsed them, and we came down to 36 questions. We sent those around to our panel in a first Delphi round, and we asked our panelists to rate the importance of each one. And then we took the top 16 of those and we sent it around a second time, and we said, can you drag and drop them into order? And by that means, we got the top 4 prioritised questions that were identified by consensus, really. The rating between our 2 researchers was almost perfect in terms of our synthesis. But we also needed to say, well, are these actually research gaps? And so we needed to look at the literature. So then we took those 36 questions and in parallel while we were doing rounds 2 and 3, and we developed a 2-dimensional coding matrix based on the PHCPI conceptual framework, but also the dimensions of primary healthcare organisation, such as accessibility, continuity, comprehensiveness. And we conducted those literature searches. So the inclusion criteria for these searches were that the studies had to be done on LMICs in the last 15 years. We excluded commentaries, grey literature, non-English, because we didn't have the option of translation at that point. We searched through PubMed using some a literature management software called EpiReviewer 4, which allows for shared reviews, so several researchers can both work on it at the same time. And then using the matrix, we put the selected articles relevant to each of those questions for both axes, and then we could filter for the global region and the country, and they were added to the map. And so we selected the searches were conducted by 2 researchers independently to check for coding consistency. So that's the coding matrix. So you can see workforce, team, scope of practice, service integration down one axis, and then the primary healthcare service delivery and system outcomes factors on the other axis. We found over 1,600 papers. We removed duplicates and screened the articles. We ended up with 260 included articles that were coded and put into the matrix. So of those 263 studies, you can see here the distribution of countries they were in, and the darker the country, the more studies came. So you can see that actually there was a lot of studies from Brazil, a lot of studies from China and India and South Africa. And then we produced this gap map, which is an interactive map. So it's got heat bubbles, and you can view the studies by clicking on the bubble in the cell. So I'm going to hopefully show you the interactive version. So you see that particular bubble is large. It has 18 studies, and you can go down and see all the abstracts. The very small little dots will only have 1 study. But you see, but the most important thing there is that shows where all the studies are. But the other aspect is, of course, that most of that map is white. It's empty. And so that really shows just how much in a lot of these, a lot of these particular factors, the evidence is completely lacking. So, I mean, basically, I'll take that back again. Basically, it showed that our panelists were absolutely correct that they identified where the gaps were. We then needed to develop implementation plans. So we took those top 4 questions and we asked our panelists again, who were all people on the ground in low and middle income countries, did they have a particular interest in one? Would they have the capacity to actually research this? What methods might they use? Do they have knowledge of relevant data sets or innovative programs in their country, or that might be able to be used or scaled up? And within a few days, we had 45 people putting their hands up, but we only had 4 questions. So we allocated the questions looking at who the people were, what capacity they might actually have, what judged on their previous work as well, but also we wanted to spread the work, excuse me. We wanted to spread it through different countries and different global regions. We gave them a template to produce a 3 to 5 page outline to include what was required by our grant, which was they had to put in a specific aim, study design, the targeted geographical area, who was in their team potentially and their partners, an overview, work plan, and an estimated total budget. And so the 4 particular priority questions for LMICs were these, and the lead researchers on the right. So the first one, what are the factors to be considered and negotiated for successful referral from primary to secondary care and back? That was in Brazil. How could care be horizontally integrated and coordinated among the multidisciplinary primary healthcare team in South Africa, which is sort of one of the questions we're now actually addressing in the consortium. That was going to happen in Africa. How can public and private sectors work more collaboratively to improve an integration of primary healthcare coverage, prevent fragmentation in Malaysia? And finally, how can different stakeholders support and assist the primary healthcare workforce and successful team functioning? That was in Nigeria. Our research teams from the high-income countries provided mentors to support the plan writing teams. They wrote draft plans. We took them to a workshop at a WONCA conference in Poland, and we workshopped it, and the participants there actually provided feedback and looked at, are these methods doable? Do they answer the question? And we sent those critiques back to help the people refine their plans. So it was quite a robust process. So in discussion, really, the voice, getting the voice of the primary healthcare providers and academics gets traction at the community level, and we think the bottom-up approach counters the frequent top-down decisions that policymakers might make, and therefore often you don't get the engagement, and the findings don't get translated into effective change. The large number of research questions generated suggests that there's a significant sense that evidence lacking, and the literature review didn't indicate that there was much existing evidence for the questions that came up. The strengths was we had this large panel of experts. It was anonymous Delphi. It enabled these researchers and LMICs to develop plans specific to their local contexts. Limitations was we had no time to translate because there was just time too tight. We stopped recruitment while there was still interest, so we didn't reach all primary healthcare groups. For instance, we would have liked to have had more nurses. We only had a week to pilot it, very short turnaround. And it was, as I said, difficult to get busy people from LMIC to engage in this work unpaid as investigators. We've had a couple of publications, as Bob mentioned. Now I'm just going to talk about the other groups. There was a team from George Institute who looked at the same question, but only for Asia Pacific, and then a team from Stellenbosch University that explored the gaps of evidence in Sub-Saharan Africa. So the George Institute Asia Pacific group, they conducted a literature review and found evidence gaps, and the largest gaps related to interventions to promote access and essential medicines, about patient management tools, effective health promotion strategies, and health service planning and accountability. Very little evidence at all from Pacific Island countries, which we found in our international study too. They then engaged a panel of 22 primary healthcare stakeholders from LMICs, and they did a Delphi, so they did theirs the other way round, to identify the priority questions. And the questions that they got were identifying effective primary healthcare delivery models for chronic disease, devising sustainable models of disease integration, optimizing task shifting between members of the team, understanding barriers to care continuity, future primary healthcare needs, and designing appropriate primary healthcare service packages. They also did a literature review of intervention studies from Asian LMICs to see what works to improve coverage, quality, efficiency, equity, and responsiveness. And the key themes there were looking at non-physician healthcare workers for coverage and quality of care. There was more integration with other services was needed. That community-based services are most effective when they're integrated through functional referral systems and supportive supervision arrangements, and when, of course, when they have a reliable supply of medicines. The importance, again, of community engagement and improving service demand, but there are very few studies that looked at a systems lens or looked at long-term costs or implementation challenges. There was looking at integration of non-communicable disease prevention and control into basic packages of care, building managerial capacity, and modernising primary healthcare information systems. So in the last group, which was actually Bob's group, looking at was a scoping review of community-orientated primary care in Sub-Saharan Africa, and looking for the evidence, different models, effectiveness, feasibility. And they looked at articles from the last 10 years, and they grouped them into the categories of historical analysis, models, implementation, educational studies, and effectiveness. And again, they conducted a literature review, and they found they had case studies, program evaluation, and qualitative studies. And the factors that related to implementation of community-orientated primary care were related to governance, finance, community health workers, primary care facilities, community participation, health and information training, and they found little evidence regarding the effectiveness of community-orientated primary care. So they came up with 9 principles from identifying from different models about defining community, multidisciplinary approach, comprehensive and equitable approach, analysis of local health needs and assets, and prioritisation of health needs, community participation. Things need to be evidence-based and scientific, and there needed to be service integration around users. So that was the sort of the work that we did before the consortium started. And as Bob said, when we first met, we actually took all those questions, those gaps, and we synthesized them into prioritized research questions from all the projects, and then prioritize these questions to help direct research endeavors for primary health for the consortium. And the implementation plans that our colleagues from Malaysia, Nigeria, South Africa, and Brazil, those plans are now helping to inform methodologies and some of the studies the consortium's working on going forward. So that's it from me. It was a bit of a rapid run through, but I'm very happy to take the odd question, and then I think we have a longer question time.
Great, thanks, Felicity. So I would encourage people, if you have a question, to post it in the Q&A. There is one question, Felicity, which I think relates back to the very start of your presentation, which is more about this issue of sort of nothing about us without us kind of thing from LMICs. Let me just see. The question actually is what will be the strategy from the consortium to ensure that future research is more representative of researchers, leading and participating from LMICs, in areas of capacity building, researching, fundraising, grant writing, etc.
Well, I think what needs to happen is that they need to be the principal investigators, and they need to get they need to have appropriate funding. There needs to be funding for investigator time, and that wasn't the case in our initial project. It was a very, very small grant, and it really only paid for some project management. But going forward, what they need to and what we're doing is applications for grants where the PIs are from low middle income countries obviously with support from the consortium, but they actually get appropriate funding to be able to work on this, and to go to their institutions, and they also need enough time. You need to have the first projects were incredibly time limited. Needs to be a little bit more realistic in terms of how long it takes to do this sort of work. And you, Bob, you want to add to that?
Well, I think the members of the consortium do mostly represent constituencies in lower middle income countries, including WONCA, because you're a global organization, so your membership extends across all sort of income country groups. And I think the challenge is, as you said, is to ensure that research is led by people from lower middle income countries, while you're also looking at the issues in lower middle income countries. And that's certainly where we're going. So I think the funding applications that we're putting in now would be led by people from South Africa, Malawi, and Bangladesh in the next one. And that is certainly the very sort of conscious intention that the work should be led by people from LMICs. So thanks for that question. I did see another question pop up on my screen, which I think was about COVID, but it's not in the Q&A. So so if you've got questions, put them in the Q&A, not in the chat, because I can't keep track of both. But the question in the chat is, okay, so is how does COVID-19 affect these priorities? Because it has shifted the global context so significantly. So I suppose that the question really is, are these questions still relevant, or have they actually now been overshadowed by COVID-19?
Well, I think they probably are still relevant, because a lot of the questions are to do with primary healthcare integration. And primary healthcare integration, primary healthcare is public health and it's primary care. It's in combination, that's primary healthcare. And it's it's becoming very obvious that countries that are most successful actually have a strong public health response, but also a primary care response, and that there's an integration. And most of our questions were about this. They're about horizontal integration, they're about vertical integration. So we didn't just have siloed programs. They're about public-private partnership, public health and primary care integration as well. So I think it's, if anything, more relevant now. Certainly questions might need to be tweaked to sort of focus more on COVID, but the same basic principles are applying. That the most important response really for a country to deal with something like a pandemic is it has to be community-based. It has to reach the people. It has to be primary healthcare based. And an integration of public health, but also community-based primary care.
Great. So now the questions are starting to flow now, but we're going to move on to Robert, where we'll come back to the questions. So keep posting them at the end. Can I just ask two very practical questions, Felicity? That evidence map, your live interactive map, looked very interesting. Is there a URL for that? Can people go to it?
Yes, there is. Shall I put it in the chat?
Put it in the chat. And,
yeah, I'll do it.
My other question was, your 4 priority questions were very country specific, but were they intended to be specific to those countries, or was that just the countries that kind of took on those questions?
Initially they weren't country specific at all. They were absolutely general questions, but we got 4 people from 4 countries. They also said we would be happy to work across countries with other countries to answer these questions. So they weren't at all country specific. It was just that's who put their hands up to write the plans. Great,
thanks. So we'll come back to you, but now we're moving over to Robert Marten from the Alliance. So Robert, the floor is yours.
Okay. Good morning, good afternoon, and good evening, colleagues. Thank you again, Bob, for that warm introduction, and thank you to the organizers, Manushi, Praveen, for the invitation to be here. I'm happy to be here. I also see among the participants some friends and colleagues, so really, really nice to be in this online setting with you. I'm based at the Alliance for Health Policy and Systems Research, and I'm going to divide my presentation today into 3 parts. So if we could go to the next slide. So first, I'm going to start with some background on the Alliance. What is the Alliance? I'm then going to talk about the Alliance's past work on PHC. And I'm going to close with our future work on PHC, and I'm hoping then we can pick up on some of those questions that we started to get into just now with Felicity. So next slide, please. Background on the Alliance. Right, so what is the Alliance? The Alliance is a hosted partnership based at the World Health Organization. We sit within the Science Division. We have our own budget, we have our own governance, we have an independent board, an independent advisory committee, but we work to support institutional capacity for the conduct and uptake of health policy and systems research. We stimulate the generation of knowledge and innovations to nurture learning and resilience in health systems. And we focus on increasing the demand for and the use of knowledge for strengthening health systems. So that's some background on the Alliance. Next slide, please. Okay, so now I would like to give an overview, a quick kind of high-level overview of the Alliance's work on primary health care. First, we'll start with the work that we've done on premises. We'll also talk about the work that the Alliance did in preparation of the Astana Declaration and the operational framework on primary health care. We'll then talk briefly about the BMJ Global Health special issue that Bob and Felicity actually both mentioned already as well. We'll talk about some more recent activities around embedded PHC research consultations that happened about 6 months ago in July last year. We'll also talk about another collection of case studies, Achieving Healthcare for All, Primary Healthcare in Action, a book that came out late last year, as well as a bulletin theme issue that we co-edited, guest edited late last year. Next slide, please. Next slide, please. Oh, perfect. Nope. Yep. Great. Okay. Great. Perfect. Thank you. So one of the things that we started in about 2016 was to develop a series of case studies. We looked at about 20 countries. It's a mix of low and middle income countries, as you can see here. And what we did here was we looked primarily, largely at primary care systems, looking at governance, looking at how primary care fit within health plans and health systems reforms. And for each of these countries, we commissioned a team of researchers based in these countries to conduct research to understand what was happening around primary care, what were the kind of challenges, what were the issues. And in each of these countries, we produced about a 5,000–6,000 word case study and then a shorter case study. Now, these case studies were helpful in terms of the background for, next slide, please. For the preparations for the Astana Declaration and the development of the operational framework on primary healthcare. So I don't think I need to spend too much time on this with this audience, but I think everyone's familiar with the 2018 Astana conference. This was really meant to refresh and revisit the historic 1978 Alma-Ata Declaration. I think what's really important here is that there was a lot of emphasis, a lot of focus on developing an operational framework, right? So trying to transform the kind of lofty ideals, the aims and goals of the 1978 declaration into something, okay, what can we do? How do we do it? And I think if you look here at this framework, it focuses on primary care and essential public health. As Felicity was just mentioning, but it also importantly includes empowered people and communities, as well as multi-sectoral policy and action. And this is really the kind of Astana framework, a comprehensive understanding of primary healthcare. This operational framework also includes 10 policy levers that help us kind of focus and look at actions when we think about operationalizing PHC. Of course, one of these levers is also research, and that's something that we at the Alliance are particularly pleased to ensure that this was part of the framework, so that when we think about operationalizing primary healthcare, we think about kind of embedding research into the process. Since 2018 at WHO, there's now a special program on primary healthcare that helps take this work forward. And we work at the Alliance, we work very closely with this special program, particularly on the research part of primary healthcare. Next slide, please. So again, as we mentioned before, I think both Bob and Felicity mentioned this, the Alliance was very happy to be involved and engaged in sponsoring and supporting this BMJ Global Health special issue that came out at the end of 2019, where we sought to capture the voices of policymakers and implementers, researchers, and others to really kind of hone in on PHC research as a way to accelerate progress. Next slide, please. Whoops, right there. Yep, perfect. So something that we supported more recently, this was in July of last year, and this gets into, I think, the question a little bit around COVID that we saw in the previous presentation. Given what's going on with COVID, we really wanted to understand what was happening around PHC, how were countries responding, how was a PHC approach being used in response to COVID. And so what we did was convene, oops, sorry, could we go back? Yes, can we just stay there for a second? Thank you. So what we did was convene policymakers and researchers from about 25 countries in the Asia Pacific region. And we asked them, what were the challenges that they were facing around primary healthcare? What were the research issues that they were seeing? And through that, we prioritized a set of research questions. And we've looked at how to kind of embed PHC research into the policy response. Next slide. Something else that we were very happy to support is a book that also came out at the end of last year, a series of case studies looking at primary healthcare in action and really providing a kind of historical overview, building on some of the previous work like the Good Health at Low Cost case studies, another contribution here on looking at kind of concrete case studies of primary care healthcare in action. Next slide, please. Something else that we were very pleased to support at the end of last year was a special issue of the WHO Bulletin, which we guest edited with the Integrated Health Services Department and worked also in collaboration with the Special Program on PHC, convened a large group with inputs, I think actually from some of you in the audience here today, a number of really outstanding papers looking at primary healthcare and really kind of trying to realize the vision as we wrote here. Next slide, please. Again, here, I think it's just important to highlight that in this bulletin, we had a very powerful commentary piece from Dr. Tedros, the Director General of the WHO, kind of underlining again that COVID-19 has underscored the essential primary healthcare principle that protecting and promoting health requires a whole of government and a whole of society approach, and it is really, if nothing else, strengthens and needs to strengthen our resolve for primary healthcare. Next slide, please. So what is the future? I think, again, we started to get into this in the discussion last time. I really appreciated the question on COVID because I think COVID does many things. But it most importantly, I think, highlights and kind of underpins some of the existing challenges. I think we've seen how it challenges every country's health system, not just LMIC countries, high-income countries, really every country across the world has been challenged, has been struggling to grapple with COVID. I think we have seen that countries which have not used a primary healthcare approach have also struggled. Most countries haven't. Countries have struggled to maintain essential services and manage emergency health services. And we know that there are critical gaps on how to develop and support and sustain engagement across the levels. There's also challenges, as we alluded to in the last session, about integration, really important questions. And so what does this mean, and what are we thinking? For us at the Alliance, we're thinking about how we can use and how we can leverage the opportunity of the COVID pandemic to kind of re-emphasize a focus on primary healthcare. Next slide, please. So what are we thinking and what are we planning? So we are planning to document and assess evidence on how existing efforts to advance primary healthcare have been affected by the ongoing COVID-19 pandemic. We're planning on distilling lessons learned and synthesizing evidence on best practices to inform ongoing and future processes. We're hoping to contribute with this evidence and with additional country case studies to the 2022 global report on PHC that is now being planned. Next slide, please. So what are we concretely doing and how are we doing this? We're going back to the 20 premises case studies that I shared earlier, and we're going to be using those case studies as a baseline, but we're going to be expanding the framework that we use for analysis. So in those case studies, we looked primarily at primary care. Now we're going to be using the Astana PHC framework, so looking at primary care, community engagement, and multi-sectoral policy. And with this framework, we're going to actually even expand it a little bit further to look at 5 themes because of the ongoing COVID situation. And as you see here, we're going to look specifically at how countries have responded and are responding to the ongoing pandemic. Next slide, please. So the framework that we're going to be using, and you can see this here, we're really focused on understanding what's happening because of COVID, right? So we want to understand and look specifically at how countries are scaling up and managing critical emergency services and how they're maintaining essential services. Obviously, those 2 points are critical for COVID. We want to also understand how countries are managing referral systems to ensure appropriate distribution of service load. This, of course, gets into the questions about integration as well, above and across. And then, of course, we're very keen on understanding how communities have been communicated with and engaged, both from a top down, but also from a bottom up. Excuse me, can we go back to the, thank you, from a bottom up perspective. So how are communities engaging? How are communities reaching out to policymakers? How are communities putting forward their needs? Because I think we've seen a lot of interesting, innovative examples of this around primary healthcare and particularly in response to COVID. Finally, we're also really interested in understanding the broader health determinants and how countries are working multi-sectorally to improve health. And I think, again, in the kind of context of COVID, we're seeing a number of interesting examples here of how countries are working across governments, working with different partners, working sometimes with the private sector, also how they are sometimes considering broader determinants. I think we've seen some very interesting interventions around alcohol, also even around tobacco in the COVID context. And I think we want to understand these interventions as well as they relate to primary health care. So over the next 6-9 months, as I mentioned, we're preparing a kind of refreshed round of premises case studies, probably with a handful of additional countries as well. So we'll probably have about 25 country case studies, and we're hoping that these will be integral inputs into the 2022 global report on primary healthcare, and we'll also be synthesizing and distilling these to develop a further prioritized research agenda around primary healthcare. So I'm going to stop there and really looking forward to the questions and to the discussion with all of you today. Thank you so much. Back to you, Bob.
Great, thank you very much, Robert. Lots of interesting information there and resources that you've kind of made us aware of. Yes, so please, I encourage people to put your questions in the Q&A for Robert and for Felicity. So I'm just going to go now and have a little look at some of the questions that have come up. Okay, so oh, they're coming in thick and fast. So this one from Harsha Joshi. I'm interested to know about the strategy to ensure that findings from research are incorporated in the practice. What is the form of collaboration with implementers in low and middle income countries? I think that's probably more for you, Robert, but I think either of you could answer that.
Perfect. Thank you, Bob, and thank you for the question, Harsha. I think this is spot on. I think this is a really important question for all of us. And I would say, you know, as both as researchers and as policymakers, we need to think about this more. From the Alliance's perspective, we like to try to think about this from the beginning, and we think a lot about embedded research. We like to think about pairing and bringing researchers and policymakers together from the very start. Actually, yesterday we launched a new special collection of the BMJ on co-production. And this is really about the idea of bringing together researchers, policymakers, communities, patients, knowledge users from the very beginning to develop research questions, but also then to conduct and eventually use research. And so we think it needs to happen from the beginning. Obviously, there's a number of challenges and questions about how to do that, when to do that, where to do that, but it is indeed very important. So thank you for the question.
Robert, you used that term earlier in your talk, embedded research. I think it was the title of an article. What do you actually mean by embedded research?
Thanks, Bob. I think what we mean is that research that is embedded, integrated into the policy process, so that as policymakers are thinking about developing, implementing new policies, that research is part of the process. And we see that with the operational framework for primary healthcare, that PHC research is part of it. And I think we want to ensure that people are thinking about that as not something that academics do, that universities do, that people do in kind of a separate space, that it's really part of the policymaking process.
That's great, and well, I mean, I could also think of examples of that from South Africa. You know, in the COVID epidemic, I mean, we actually have, you know, been addressing policymakers' questions through research, and that's influenced the response and so on. So that's really helpful. Felicity, there's one for you. It says from Pingfu Wong. She wants to know, I would like to ask if there is any good model on public-private partnership that we can follow. That, yeah.
Well, I think every country does it differently. I mean, it's probably easier to say where it doesn't work. But I mean, I think in New Zealand, we have a blended model, which works reasonably well in that we have public health is all public. It's all funded by the government. Primary care is a mixture of government funding and fee for service. And COVID has actually helped us get a better integration with our public health and private sector. It's not perfect, but it actually works pretty well. And at times where there's great need, the government can call on the private sector and use the private sector's resources. For instance, you know, if there's waiting lists get too big in the public hospitals, they can use the private hospitals. So I think, you know, there are quite a few models out there, but generally, when you look at countries, they're often very siloed, and the private system is working completely independently from the public system, and it creates, of course, huge inequities.
Thanks, Liz. Maybe Robert, do you have any input on this one? Effective public-private partnerships to strengthen primary healthcare? Okay, right. So there's another question here from Steve Reed, who says that in some ways the pandemic has actually strengthened a sort of top-down approach to the whole of society. You know, I guess lockdowns and regulations, and of course in South Africa they've been quite harshly, implemented in some cases. But he says, but primary healthcare emphasizes community engagement and participation, which has been very weak if it has happened at all. And of course, that's one of the reasons behind people's hesitancy to get vaccinated, lack of trust in the health services. So his question is, how can research strengthen such a bottom-up approach of community engagement and participation? I think that's for both of you.
Well, thanks, Bob, and thank you, Steve, for this question. I think this is spot on. I think actually there's been a lot of really interesting examples of bottom-up approaches. I think it's absolutely critical. I think the link with research and researchers is important. I think it, again, for me, kind of emphasizes or underscores the importance of working with local researchers, researchers that understand local context, local situations, local communities, and work with people on the ground to kind of develop and influence and shape the policies that affect them. And obviously the example with vaccines, I think it can't be more clear. So thank you for the question.
Great. Felicity, any comment on this one?
I don't think I've got much more to add than that.
There's a sort of related question here from Maurizio Calderon, who says that while health systems in Europe seem to have failed to use primary healthcare settings to support and steward community action during COVID, he's asking, are there successful experiences for this coming from LMICs? In other words, are there any good examples of community engagement, participation, action coming from LMICs? I would have to say that I think, well, in South Africa, I can't think of particularly good examples. In fact, I think this has been a weakness of the response, the lack of engaging in with communities so that they understand what's happening, so that there's trust in the interventions and the plans around vaccines and so on. So yeah, but maybe Robert and Felicity, you're aware of some good examples of this.
Well, thank you, Bob, and thank you, Mauricio, for the question. Mauricio and I actually worked together in Sierra Leone, which comes to mind in terms of a country that's using the lessons from Ebola in its response. I'm sure, Mauricio, you've also stayed in contact with colleagues from Sierra Leone, but I've been hearing a lot of interesting examples about how people are still using the temperature checks, the hand washing, a lot of kind of community support groups are kind of banding together and collaborating across neighborhoods, across groups within Freetown and other geographies in Sierra Leone to respond to COVID. That to me is really striking, and I think is something that we have seen not enough of or not enough attention to in the COVID response.
I mean, I think even in South Africa, we've seen quite strong civil society response, particularly around sort of food security, sort of social vulnerability. They, set up what they call CANs, community area networks, often with faith-based organizations, to provide people with food, basically during lockdown and other resources. So I think civil society has to some extent stepped up, but I think health services, I think this is a weak area. So let's see, There's an interesting question here. It's a big question. Ashutosh Naik asks, okay, it's all very well to identify the evidence gaps. That definitely helps. But how do you address the question of political will in LMIC? So there's a lot of countries where, quite frankly, the government maybe isn't that committed to strengthening PHC. So how do we address that?
I mean, I think Robert's suggestion, you know, of when, if you can engage the policymakers and embed the research at the onset, you know, you may well be able to get a little bit more traction with government. I mean, it's going to take advocacy and lobbying and sometimes changes of government, but I think just keeping the message going that primary health care is where you're going to get the most effective bang for your buck, really, in terms of you know, changing and improving health outcomes for the equitable health outcomes for your whole population. So, and I think it just needs, the message just needs to be kept being made loud and clear, and you know, from organisations like WHO, clearly, and WONCA.
Yeah, no, I would agree with Felicity on that. I think that's absolutely important, critical to get the political will. I think that it's also possible for researchers to, as we were saying, yeah, kind of develop the relationship with policymakers to provide the evidence, but also to help them think about how they frame the evidence to use it to make the political case. And I feel like it could be, sometimes there might not be kind of a political window, but researchers need to kind of have the relationships, have the evidence, have the plans ready for when windows of political windows come and go. And so I think it's about kind of developing the relationships, developing and having the evidence on hand, and having the framing right for the political moment. Not easy tasks, but I think there are some good examples. I think, you know, in Thailand, they talk a lot about the triangle that brings together researchers with the society, with policymakers to move the mountain and to move the reform that we all want to see. Over.
Thanks. So, there's a question that's a bit more specific and a bit more health related directly from Lindsay Farrant, who seems to be concerned about palliative care. And she's saying there's evidence for the palliative care needs of patients with NCDs, but very limited access to palliative care in low and middle income countries. COVID has also highlighted the need and the lack of access to palliative care. She says there is a move to integrate palliative care into primary health care as supported by the Astana Declaration. And she says, I would be interested to know how this fits into the research agenda of the Alliance and the Consortium. Yeah, so maybe, Robert, you want to go first on that one?
No, thank you for the question. I think it is really important, really critical. On this one, I would actually have to defer to one of my colleagues who's actually leading some work and working with some of our colleagues in WHO on the palliative agenda. I know they're developing, I believe, a new Lancet commission around this, looking at palliative care and finding ways to improve emphasis on this and looking at ways to integrate. But I would have to come back to you with more specific information on that. Thank you.
Felicity, any
comment? I mean, I agree that, I mean, palliative care is, from my point of view, has always been part of primary care. You know, it's probably become more separated out than it used to be. It used to be that, you know, particularly in high-income countries, but you know, that family doctors would look after people from, you know, cradle to grave, and it was very much part of what you did. I mean, I think now that it's become more of a specialised area, sometimes it may, it may not have that integration. And again, I think, that if you look at what really primary healthcare is all about, it's about community-based care. It's about maternal care, and it's about rehabilitation, and it's about palliative care. And how you put all those bits together, I think, the model that you use depends on, who your teams are and how they're integrated. Going back to our original questions, really, that we need to have comprehensive horizontal care provided for a whole community that will include, care at the beginning and the end of your life, as well as all the way up the journey through. And I think different countries will have to have different solutions to that. But it certainly needs to be seen as something that's very much part of the whole.
I think what you're saying in a way, it's not specifically mentioned, but I mean the concept of comprehensiveness, which is very much central, I think, to the primary healthcare approach, definitely includes, palliative care, actually, as well as rehabilitation, treatment, health promotion, disease prevention. That the whole spectrum is part of what is meant by comprehensiveness. Yeah. And so palliative care is in there. It may not be in the headline, but it's definitely in the sort of the following on text. And I think in low and middle income countries, it often involves task shifting, doesn't it, to other health workers, community health workers, and other people to provide some relevant primary palliative care in the community. Certainly for rehabilitation, that's also like the direction that South Africa has gone, because like palliative care specialists, rehabilitation specialists are so completely scarce. Let's see. Okay, so this is to Dr. Robert from Asagid Jaleta. I think Asagid is from Ethiopia, if I remember rightly. So if you have experience working with low and middle income countries, how primary healthcare physicians contributed to primary healthcare, if there is an interprofessional collaborative research among all actors. So I think the question is, and I think this is an issue in Ethiopia and other countries, how does the primary care physician contribute to primary healthcare, and also to collaborative research amongst all the actors involved in primary healthcare? I think that's the question.
Yeah, no, thanks, Bob. I actually think maybe I'll defer to Felicity on this, because I feel like WONCA has been at the forefront of this. Felicity?
Can you reframe it, Bob?
Well, I think there's, my interpretation of the question is that there's two angles. The one is, what's the role of the primary healthcare physician in collaborative research with the other members, as it were, of the primary healthcare team? But also maybe a bigger question of, what is the role of the primary care physician in primary healthcare teams in low and middle income countries?
And I think it's going to be very country specific. Family doctors and project specific. I'm a very strong believer in as much co-design as we can do, and involving our end users as collaborative partners in research. And the end users may well be the family doctors, but they may also be other members of the team, and of course there will be community members and patients. And so it does depend on what the research question is as to how much we engage and involve our primary care doctors. And again, the role of the primary care doctor varies incredibly in different countries. In my country, generally they're community-based in clinics, and they lead a team of nurses, and there's a lot of other auxiliary workers that may be associated with the practice depending on the location and size. Whereas, in Bob's country, they may well be primary care doctors may be located in the regional hospital, and the primary care clinics are run by nurses and other workers. So they have different roles, and how you involve them in research is really going to depend on what you want to know, and how much, you always have to have a balance, because asking very busy primary care clinicians, doctors, nurses, community workers, you're asking very busy people of their time and energy, and so you have to balance involving them and engaging them with not actually overburdening them, and that can be a fine line. So I think it just really does, I don't think there's one answer for that.
I mean, if I was to attempt an answer to that question, we'll see what Robert has to say. In my context, of course, I mean, primary care is not usually offered by primary care physicians. I mean, it's normally a nurse who's the main primary care provider, and often the team, of course, also includes community health workers and others. So the primary care physician is a scarce resource, but an important member of the team, and often the sort of the most highly trained member of the team. And so we would say that one of the things they must bring to the team is sort of critical thinking and clinical governance, so helping the team to make sense of information, of evidence that might be coming from research or the community or other places, and occasionally getting involved themselves in research. So one of the things we've just started in South Africa is a family physician research network, so family physicians that are on the clinical sort of coalface, as it were, can then participate in research, answering questions that they have chosen themselves and prioritized from the clinical space, with support from sort of the more academic types. So that's some of my thoughts on that. Robert, anything you want to add?
No, just to say, I really appreciated the answers from you and Felicity.
I guess, just in terms of what you said, I mean, yes, practice-based research networks, which you've got now in Cape Town.
Got one, yeah.
But I mean, they certainly are a really good way to engage primary care doctors, and if they can have enough academic support to then answer the many clinical questions that come up, so they're questions that are important to them and their patients, and therefore they're going to be much more engaged and actually being involved in the research if they see a value to it.
So this is a sort of reflective question from Kenneth Yakubu, who is from Nigeria, I think. And I think his question is really he says, would you say adopting a positive inquiry approach alongside describing evidence gaps may have provided a rich overview of where primary healthcare engagement has worked properly in low and middle income countries? So in other words, he's saying you spend all your time focusing on what's not there, and maybe you don't focus enough on what is there and is working well. And maybe we could learn as much from what is working well as from what's not working. And any thoughts on that? No,
thank you, Kenneth. I love the positive deviant approach, and I think there are a lot of examples of things working well. So I think that's a great point, and something we need to look at more.
Felicity?
Yeah, no, I mean, I agree. I think we could go back to our gap map, the one I've just sent the URL for. We could look at those big dots and see just what's in there, and what is being shown to be effective, where there is evidence. But I agree that focusing on the positive rather than the negative could really help our learning.
Yeah, an appreciative inquiry approach. To what works, and if it works, why does it work, and how can we make it happen more? Priya Balu, I'm not sure whether this is a question or a statement, but I'll read it out. So COVID has enabled many new partnerships at the primary level, including the role of digital providers in primary health, both public and private. And then she says there is a need to revise indicators for primary care that are more relatable both with revised metrics and context. Not sure I fully understand the question, but that's what she's saying. Maybe you can react to that or engage with that. Robert, you look like you made sense.
Sure, no. Sure, no, thank you for the question, Priya. Really nice to hear from you. I think this is spot on, and I think in my mind, this is where we've seen COVID really just transform primary care, and I think we're going to see this in the coming years. It's been extraordinary. I think. I mean, I had a doctor's appointment myself a few weeks ago, and I did it online and over the phone and over the computer. It was fantastic. I think there's a number of innovations happening here. I think there's a number of kind of new challenges around this. And I think, to be very honest, I don't think we have a good purchase yet, a good sense of how quickly this is happening. I think we all need to do a better job of understanding this better and highlighting kind of best practices. This is something that we're actually very keen to do for the 2022 PHC Global Report that I mentioned earlier, because I think that things are just happening so quickly, but I think we need to get a better overview and begin to kind of highlight not only where things are working well, but some of the new challenges around these digital partnerships.
I mean, in South Africa, go on.
Sorry,
yeah.
Bob.
Felicity, go for it.
So I think it's been a colossal and a rapid development. And as I say, a lot of pluses. One of the things that it may well be doing is that it may be increasing inequities, because people who don't have access to the communication networks, to the cell phones or the internet, may well be missing out. And so we need to be very clear that it's not actually making inequities greater. But one of the more positive things I think it's doing is that it's really accelerating task shifting, so that nurses, whereas a doctor might have done a consultation, a nurse or a community worker is stepping up and actually because the need is so great and everything's happening so fast, there's a lot more people working at the top of their scope. But again, we do need, as Robert says, we need to make sure that the quality remains there, that actually the safeguards, so that actually the care that's provided is optimal at the same time. Sorry, Bob, you go on.
No, I was just going to reflect that in my context, most people, even in the poorest communities, have a cell phone, and these days. And so, how does one leverage, cell phone technology? And I mean, during the COVID pandemic here, I mean, our primary care facilities sort of woke up to the fact that they can communicate with patients via WhatsApp, and have made hugely effective use of WhatsApp to send out information, to receive questions, to answer questions, which has never happened before. And of course, patients would try and phone in, on the traditional telephone, which nobody ever answers. So the whole connectivity, actually with the population that you're serving has suddenly improved in a way through the use of things like WhatsApp. And we're now looking at, even creating sort of health education programs, using just little voice messages and graphics over WhatsApp. So very low data into communities where they've got enough data to receive that. So definitely this whole digital, I know that Robert was talking more about teleconsultation, telehealth, which we've always had a little bit of, but not so much. But it has really changed the way that we do business, as it were, in primary care. Yeah. Good. How are we doing for time? We've got a few minutes left, so maybe 2 more questions, then we wrap up. So Gulnaz Mohammed, who's I know is from Kenya, from Nairobi, she asks, you have any recommendations on primary healthcare, models of care that are applicable to private organizations running primary care clinics at the community level. So I know she comes from the Aga Khan world, and they have a series of primary care clinics in Nairobi. So any recommendations on how private organizations can do that better or well?
Well, I mean, I think one of the things I think, if you're going to, whether you're private or public, that it's really useful to have an enrolled population. So you actually, this is the population I'm looking after. They're registered with the service. And so you don't just provide episodic care, you actually look at providing population-based care as well in terms of vaccinating your population, in terms of screening. You again, I mean, it comes back to integration. So you might have a private system, but when are you going to collaborate, coordinate with the other services out there, albeit they, public services, community-based services, more sort of general public services, public health services. I think you basically, the less siloed a system is, the more that they're looking after a discrete population, but they're actually looking after that means that they can look at the whole of society, the whole of the country health system, and make sure that their patients can have access to it. And of course also, I mean, the trouble with the private system is that it may well be a barrier for a lot of people, and are they creating a dual system by having it? So how much can they try and prevent that, the haves and the have-nots, one gets a really good health system and the other doesn't get much health care at all. Robert, you could probably expand on that much more than I can.
No, I think that was fantastic, Felicity.
Good. Yes, I do know a little bit about the context from which that question is coming, and I think yeah, it's a strange mixture of different leverages in the private sector. They're very different to the public sector, and have to think about in a way, to what extent, as you say, those primary care clinics are taking a view of serving a particular community, offering a comprehensive service, in a way, maybe not just being an avenue into the tertiary hospital kind of thing, but actually offering a fully comprehensive primary care service. Yeah. Last question. I'm sure your brains are tired now. From Lindsay Farrant. So are there examples of research into interventions and models of care that enhance person-centered care in primary healthcare in low and middle income countries? So have you got any good examples of research or models of care that actually enhance person-centeredness, which is obviously one of the key principles, isn't it, in primary healthcare in low and middle income countries?
I can't think of any. Doesn't mean to say they're not there.
Yeah, no, thanks. I can tell you in about 6 months, we'll have a new round of about 20, 25 case studies that will hope to answer this question.
Very good.
Okay. We must wait. Okay. All right, I think we're going to call a halt there. I can also tell that Robert and Felicity, we've really given them their brains a hard grilling. I'm not sure whether they're going to get the job, but thank you to Robert and Felicity for your willingness to engage with a really diverse range of questions and for your presentations. Manushi, do you want to have the last word and any housekeeping announcements and then bring us to a close?
Thank you, Bob. The session was very interesting, and thank you to everybody for all the questions. I'm sure you have a lot more questions, but I invite you to engage with us on our Twitter handle, which is care@care_PHCRC. And we should be able to answer your questions over there.
Thank you to everyone. Thank you to everyone for being here, for staying with us, for participating. We hope that it was useful and valuable. And maybe see you in our next webinar. But for now, goodbye and thank you.
Bye.
Thank you.
Thank you.
Thanks, everyone.
Bye.